Dear friends, dear colleagues, thank you for joining my session. This talk is about the long-term effects of sepsis and septic shock on family and children. I have no conflict of interest to declare. The objectives of this presentation is to provide an overview of the long-term impact of sepsis and septic shock on family and children. That will be a challenge, I guess. And as today we have covered, and we talk a lot about impact of long COVID. So we try to sort of present also the perspectives of giving some space to the family and patients' experiences and their viewpoints, and what we actually did to support the parents and family members during COVID, just to prevent critical illness in sick children. I like to start with this painting, just because I like it very much. It's hanging in the Tate Britain Museum in London from Sir Luke Fielders. It's called The Doctor. And this represents actually what we like to prevent, particularly if this child would have sepsis, a septic shock. And I think the whole presentation is around us professionals taking care of children, as well as having the parents, which you can see here at the background, who are actually anxious and sat up all night. The painting is inspired by the death of the artist's son and the professional care. So I'm really pleased to sort of start off with this artistic view of my presentation. But I like to set the scene first. What are we going to look at? And it's all about the impact of sepsis, septic shock, where you have this pathway where children coming into the PICU. Overall, we usually talk about patient and family-centered care and our care delivery in the ICU services. We then go, obviously, to hospital discharge and home. But what is this whole process, this process of critical illness? And I think if we look at long-term health, this sort of impact has a name, and it's called the post-intensive care syndrome. Started off in adult intensive care. They also developed the post-intensive care syndrome for family members. And Joseph Manning actually and his team has created the post-intensive care syndrome Paediatrics, the PICS-P framework. So this is the framework published by Joseph Manning, the post-intensive care syndrome P, where you can see the child is in the middle of the center of the first line. It has four main domains: physical health, cognitive health, emotional health, and social health. And if you look particularly at the family members, the parents, the siblings, and you might even not forget the grandparents, these long outcomes we need to look at are the emotional health and social health. So having this framework is really important for us to further develop and understand the impact of sepsis and septic shock, particularly on long-term issues. So I like to address a little bit and start off with the parents in the PICU. Where are we at with parents, particularly when the critical ill child is surviving a sepsis illness? And coming back to the long-term effects is Joseph Manning's the Oceanic study, which is now hopefully giving us some more time to look at in-depth outcome measures, long-term outcome measures of a critical illness. And for example, here you can see the child and parental siblings outcome measures, where the parents actually outcome measures are measured anxiety, depression, post-traumatic stress, additional caregiving roles, and a change in social status. But what you do know currently from the literature from Schudy, Colville, Rennick, and previous work from Joseph Manning and all across the world is there is an impaired health-related quality of life, there's an impaired emotional well-being, as well as functional disability. But we do have limitations in most of these studies because some are very specific based on medical conditions of the child. It's focused on age groups. There's no assessment of baseline. There are singular outcomes only, and there's some limited follow-up at one time point often. So we need robust new evidence that tells us actually what is the long-term outcomes of a critical ill child and the family member. We do have a very nice overview, a systematic review, looking at the impact of pediatric critical illness and injury on family members. So the work done by Carla Abela and her team, what they haven't included perhaps in this systematic review, this update actually, this is the second review they done, it's an update, not included pediatric cardiac intensive care units. Families may have different experiences within the subspecialty of critical care, given the differences in clinical team structure, patient conditions, and available hospital resources. But in contrast to families in PICU, we must say that families in pediatric cardiac intensive care may interact with a more consistent group of clinicians. So there might be some differences in the services given. Now, what they actually look at, they included 33 studies, of which 16 were qualitative studies, 15 quantitative, and there were only 2 mixed methods. What is not surprisingly already what Manning also identified as a rationale for starting off his oceanic study is the sheer amount of outcome measures in all the studies. So in the 15 included qualitative studies in this review, you can see a whole list of different outcome measures. But the different outcome measures might actually measure a general outcome, such as stress or such as anxiety. Because you can see studies have been using the parental stressor scale, the self-rating scale for post-traumatic stress, the hospital anxiety depression scale. So this number of scales, the differences of the number of scales, actually limit us to look at really robust meta-analysis of outcomes in combining all these studies and giving some directions, future directions. So this review actually highlights that parental stressors include signs and sounds within the PICU, the child acuity. Well, obviously, this might be specific for those children with severe sepsis. Changes in family functioning and parental role, and the uncertainty of the child's outcome, which obviously, if you talk about children with septic and septic shock, might be in a severe level. And that cohort of patients or children with severe sepsis might impact on the family members' outcomes as well. So the psychological, physical, and social impact of hospitalization were experienced by parents from days after admission to even years. So we talk about long-term effects of critical illness, particularly in this session in sepsis and septic shock. We do know that some of our parents do have long-term impact and experiencing difficulties years after discharge of their child. Now, spirituality has identified as a coping mechanism in half of the studies that were included, and the most common needs of parents that was identified was being well informed. Now, if we talk about well-informed, we know already for many, many years the needs of parents. We know this for a long time. So the well-informed is one of the top priorities in the basic needs and wishes of parents. being informed of how, what, when, and delivered in an understandable way is really important. That influence actually the long-term impact on parents. So basically, when you look at the whole family setting, parents, siblings, grandparents, and significant others, including their pets, are important partners in the care of a child during the critical illness. So we're going next to survive now what? So looking at what's happening with our critical ill children and how are we following up. I like to share this slide with Joseph and I. We've done this together with Barney and a whole team looking at the follow-up provision in the United Kingdom and Republic of Ireland. Because we certainly were not sure what kind of services, follow-up services, is delivered in order to understand the long-term impact of critical illness. And I think the aim of this survey was to, or this study was to determine the characteristics and content of in-hospital and post-discharge PICU follow-up across the UK and in the Republic of Ireland, and to evaluate the clinicians' perceptions of the importance of follow-up. Now, what you can see here is that only 45% of the PICUs in the UK and in Ireland offered early follow-up periods and services in the hospital. And of the 10 PICUs, 4 had procedures guidelines. The time to contact was early in 24 to 48 hours, and aftercare was provided by doctors, nurses, and physiotherapists, only a few of them. So there's not a lot of follow-up care in the hospital so far. When we look at post-hospital discharge, the PICU late aftercare was only delivered by 3 pediatric intensive care units. So of these 3 pediatric intensive care, none had a policy, guideline, or procedure. And the forms of contact included telephone consultation or rehab clinics. And I think the only one of the rehab clinic that's possibly the best follow-up you might have, because that's where you collect data for long-term follow-up after critical illness. The time of contact was between 1 to less than 3 months. Aftercare was provided by the doctor and the psychologist. Care needs assessed was dependent on case by case. So there's not much structure in our follow-up services. And should we do that? Yeah, we should, because we have the NICE guidelines of ICU services in the UK, where the NICE guidelines actually say that every intensive care unit should organize a follow-up position service. So in order to understand this whole phenomenon of the long-term effect of critical illness, this is Joseph Manning's Oceanic study. The aim of this mixed method study was to understand the physical, functional, emotional, and social impact of children and their parents first year after a PICU admission. And we might hope when he's finishing data collection recently. So we will very much looking at the results coming up, and we hope actually to see if there's any possibility for special cohorts of children who have experienced septic shock. In terms of the parents, the role of the parents then, this is the work we've been doing with Lorraine and Amanda in Australia, in Queensland. Amanda is the designated nurse to provide the sepsis campaign in the country there. That's a statewide campaign. We look actually at the role of parental concern in recognition of the sepsis. So this was the review we did of the papers. We identified 11 Atlantic criteria, but actually only one article was prospectively assessed the diagnostic performance of parental concern. So only one so far, but there's a lot going on in the world. So what we identified in the literature 2 years ago was that something is wrong, was defined as a subjective feeling of the physician that things were not right, and similar but not identical was the sign different illness, which was defined by as a statement by the parents. So there's a lot of work going on in various countries, some using early warning systems. The work by Dr. Fenella Gill is in Perth area aligns a little bit on a different level to include parents in the early sepsis campaign almost to identify deterioration of children in the hospital, but also meanwhile her work continues outside the hospital settings. And the work obviously with Amanda Harley, who's really important as a statewide sepsis campaign initiative to detect as early as possible. The second aim was looking at the COVID. I was asked to discuss a little bit about COVID, but obviously we have hundreds, thousands of studies done about COVID. But I think what I'd like to address a little bit about the work we done early COVID, the first few months when COVID hit and when we went into lockdown. So this is the work we've been involved and we did together with Emma Lim. Dr. Emma Lim is a consultant in pediatric infectious diseases at Newcastle in the UK. And we actually developed a leaflet for parents that was already developed before COVID hit. But then when COVID hit, we all experienced in the UK, the first wave particularly, that parents didn't come with critical ill children to the emergency department or GPs. So we actually released this sort of leaflet we created. So this was the leaflet, how to recognize if your child is seriously ill. It gives all the signs and symptoms that's based on NICE guidelines and other guidelines that are available. This leaflet has been developed with parents, for parents. That's really important to address it because Carrie Doherty, one of the authors, is a parent with 5 children, and she experienced a critical illness of one of her young children a number of years ago. So having parental perspectives in developing their work, actually their information provision is really important. So what we did is actually we evaluated it among a small group using social media, because the leaflet was distributed to schools via emails very widely in the country, up in Newcastle area. So via social media, we had 171 parents responding to our short survey. We actually were mostly concerned about and looking at their confidence. And the last question, as you can see, after reading this leaflet, how do you feel about recognizing if your child is seriously ill? The majority felt more confident. Less parents, 55, told us that it was the same, and there was nobody who was saying, hey, I'm less confident looking at and using the leaflet we provide. There was also an open-ended question with feedbacks. We did some content analysis, and 3 main issues came out. Knowledge, so the leaflet was an objective source to validate their concerns. The usability, that parents thought that the leaflet was clearly designed, and the decision aid, the leaflet provided a clear clarification about recognizing of serious symptoms and when and where to seek appropriate care. So basically, this leaflet for parents in conclusion is that the leaflet provided parents the guidance on decision making. What we don't know is the long-term effects of this provision during COVID. So we do have lots of data about long coverage of children and long coverage of adult patients. But what does it really do with the long-term impact? If you look at Joseph Manning's PICS-P framework with the 4 main domains, so we're still lacking data of. So my final words are that we have a limited understanding of the long-term effects of sepsis and septic shock on family and children. I think centralization and collaboration is needed to organize long-term follow-up programs for parents with children after critical illness, and particularly you might want to start with the specific cohorts, those children who experience a sepsis or septic shock and has been admitted in your ICU, yes or not. And I think we need robust and standardized data collection methods that are needed with the help of artificial and intelligence, possibly, to support us clinicians and children and the parents. So far, thank you very much for your attention, and I'm looking forward for the debate.